Good morning, everyone. Thank y'all for coming today. All right, I think we've got everybody in from the waiting room, and I am recording. Thank you again, everyone, for coming today. My name is Amanda Trish. I'm a Rural Health Development Coordinator with Wellhead, Louisiana. And we welcome you to the Journey to Health Equity, a Roadmap for Rural Hospitals series. Health equity is not just an ideal, but a necessity for achieving better health outcomes, especially in rural areas, which we know, where healthcare access and resources can be limited. By addressing health equity, rural hospitals play a vital role in reducing health disparities that impact minority and low income populations. This aligns directly with the CMS Health Equity Framework and social drivers of health initiatives, which guide hospitals in focusing on social determinants such as economic stability, education, and community support. Moreover, meeting these health equity standards helps rural hospitals with CMS measure reporting, supports minority health efforts, and strengthens quality for Joint Commission accreditation. When we ensure equitable health access to care, we improve not only individual lives, but the resilience of entire communities. Thank you again for being here today and for joining us on the path toward a more equitable future in rural healthcare. Our presenter for this series is Dr. Cynthia Bienemy, PhD, RN, and lead researcher for all things professional healthcare workforce research and consulting. Dr. Bienemy believes that having a racially and ethnically diverse healthcare workforce is essential in addressing the health disparities and inequities that plague underrepresented populations. Dr. Bienemy has been a registered nurse for over 43 years and has served in leadership roles in clinical practice, academia, and research. Dr. Bienemy was the inaugural director of the Louisiana Center for Nursing at the Louisiana State Board of Nursing, where she authored and co-authored over 20 studies, reports, and manuscripts on nursing education capacity, supply, demand, forecasting, nurse faculty shortage, and the diversity of the nursing workforce. Dr. Bienemy represented the Louisiana State Board of Nursing Center for Nursing as co-lead for the Louisiana Action Coalition, which focused on preparing nurses to take leadership roles in eliminating health disparities and inequities through initiatives that create a culture of health. That was from 2010 to 2020. Dr. Bienemy led the work of the Diversity Steering Committee, which focused on increasing the diversity of Louisiana's registered nurse and advanced practice registered nurse workforce. Dr. Bienemy facilitated the state's first nursing workforce diversity think tank in 2015, resulting in a hallmark report entitled Embracing the Challenge, Enhancing Diversity in Louisiana's Nursing Workforce. Dr. Bienemy has served as chair of the Nursing Supply and Demand Council and the Louisiana Health Works Commission, a board member, president-elect, and president for the National Forum of State Nursing Workforce Centers, and is currently an associate subscriber member of the National Forum. Dr. Bienemy currently serves as chair of the Acadiana Black Nurses Association Health Policy Committee and is an alumnus of the Substance Abuse and Mental Health Services Administration's Ethnic Minority Fellowship Program at the American Nurses Association. Before accepting the position as the first director of the Louisiana Center for Nursing in 2009, Dr. Bienemy was an associate professor in the graduate nursing program at Southern University A&M College. Dr. Bienemy has conducted community-based research that focused on improving the self-care practices of African American women who were diagnosed with high blood pressure through diet, exercise, and the utilization of evidence-based stress management techniques. She examined the relationship between high blood pressure, chronic stress, and depression in African American women and explored the moderating effects of social support and spirituality on blood pressure control for African American women diagnosed with high blood pressure. Thank you so much, Dr. Bienemy, for being here, and we really look forward to your presentation today.
Thank you, Amanda. Thank you very much for the warm welcome and listening to my background. It sounds like I've learned a lot. I've had the opportunity to learn a lot over the last 43 years. And the thing is, I'm continuing to learn. So as we tell students in our nursing programs, you never, never stop learning. Well, I'd like to take the opportunity to welcome everyone that took time out of their busy schedules to participate in this first of 6 series on the Journey to Health Equity, a roadmap for rural hospitals. And I'd like to let you know that Well Ahead does not take it lightly. We understand how busy each and every one of you are. And so we're hoping that you'll find value in these series as you move along this journey. Understanding Health Equity and Why It Matters to Rural Hospitals, our first webinar series. The objectives of this first series include defining health equity and its relevance to hospitals and rural communities, exploring the relationship between social determinants of health, social drivers of health, health-related social needs, health disparities, and health equity, identifying health disparities experienced by people living in Louisiana's rural communities, and describing the role of leadership in creating a culture of health equity in rural hospitals. And I know that many times I think I'll be speaking to the choir, that many of you could probably conduct this webinar. But what I really want us to start off with the beginning is to clarify some terminology, because the terminology centered around health equity can be very confusing, complex at times. And so we want to make sure we're all starting off on the same goal in terms of our understanding of health equity. Again, we know that rural areas in Louisiana make up roughly 80% of Louisiana's geographical area and 26% of its population. We know that nearly all of the state's population, 98% or 63 of the 64 parishes, lives in federally designated health professional shortage areas. So we know that, which means that this is not just about rural areas, but this is about all of Louisiana. This is about the impact that 26% of our population living in rural areas have in terms of the well-being of our entire population within Louisiana. We're going to start off with a poll question. And Amanda's going to assist me with this. And we just wanted to have a baseline of your awareness of health equity. So the question is, have you participated in a webinar or attended a meeting or conference that focused on health equity in the last 12 months? And we'll just give you a few seconds. We're not going to take up a lot of time. Okay. Okay. Just a few more seconds. Okay, so it looks like the majority, 70%, have actually, and within the last year, participated in some type of meeting, webinar, and face-to-face as it relates to health equity. And that's great. So we'll be able to share and learn from one another. Okay, Amanda, we can end our poll. Okay, so where do we begin? Health equity begins with acknowledging that all people have similar desires, regardless of their life situations, and should be treated with dignity, especially during the most vulnerable times in their lives. And usually that's when they enter our healthcare system, is probably one of the most vulnerable times in their lives. And what I want to do here is just lay the foundation that we are very similar, that the patients that come into our healthcare facilities and to our clinics have the same desires and goals that those that are caring for them have. And so we just want to, for instance, patients love their families and want them to be safe and enjoy life. We all want that. Patients want to be valued and acknowledged. They want to be financially secure. And even though we know that poverty is an extreme issue in our rural communities, that does not negate the fact that these patients still want to be financially secure and want their families to be financially secure. Patients have their own personal values and beliefs. And this is very important. And we'll be talking more about this on our journey, but that we identify and that we listen to patients when they're describing how their values and beliefs impact their health and healthcare. Patients experience conflict. We all experience conflict. It could be conflict on the job. It could be conflict at home. It could be conflict in our community. But we find ways to deal with conflict. We find solutions for the conflict. Patients have biases. We all have biases. We may not even recognize it at time, but we have biases. I read this book, The Loudest Duck, and the author mentioned something about your grandmother's always with you. And the grandmother represents all of those things, those ideas that you heard when you were growing up, even though you may not agree with them, but you've heard them. They were ingrained in your mind. And so at times when you're in a meeting, they're saying your grandmother's sitting right there with you, those thoughts and ideas. So which means that we have to be very intentional to make sure that we don't allow those biases to impact how we care for patients, how we communicate with patients. And then patients have political opinions. We all have political opinions, and we're not going to even discuss that on this webinar, but the idea is that we respect each other. We respect the fact that everyone has a right to their political opinion. And so this was just to share that we are similar in very many ways, and we're different in ways, but that's what makes us so great. So next, we're going to talk about what is health equity. There are many federal organizations, many philanthropical organizations that have defined health equity. And you have to begin with a definition in order to determine where you're going to go. And I want to just share, included within some of the PowerPoints, I've added pictures of some of our rural health facilities. So if you recognize one, please put it in the chat. And again, we want to make sure, please use the chat. If you have any comments, if you have any questions, use the Q&A. Amanda's going to be monitoring those. And I promise you, if we don't get to all of your questions during the webinar, I will follow up with you with your questions and probably bring back the answers on our next webinar. So the Centers for Medicare and Medicaid define health equity as the attainment of the highest level of health for all people. And all people is the key, whereby every person has a fair and just opportunity to attain their optimal health, regardless of their race, their ethnicity, their disability, their sexual orientation, their gender identity, their socioeconomic status, their preferred language and geography, including whether they live in a rural or other underserved community. What they're saying is that it should not matter where you live that determines your health. HRSA, the Health Resources and Services Administration, you'll find these definitions are very, very similar as we go over them. It defines health equity as the absence of disparities or avoidable, and the key here is avoidable differences among socioeconomic and demographic groups or geographic areas in health status and health outcomes such as disease, disability, or mortality. Health inequities, not health equity, but health inequities refer to inequalities that are unfair, unjust, avoidable, or unnecessary, and that can be reduced or remedied through policy action. The Robert Wood Johnson Foundation, which is probably the largest philanthropical foundation in our country that address health concerns. They define health equity as the means that everyone has a fair and just opportunity to be as healthy as possible. And this requires removing obstacles to health such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education, and housing, safe environments, and healthcare. These are considered basic needs that everyone deserves. Healthy People 2030, that really kind of identifies objectives for all of public health. Health equity is attainment of the highest level of health for all people. Achieving health equity requires valuing everyone equally with focus and ongoing societal efforts to address avoidable inequalities, again, avoidable, historical and contemporary injustices, and the elimination of health and healthcare disparities. And finally, the Centers for Disease Control. Health equity is the state in which everyone has a fair and just opportunity to attain their highest level of health. And I love this little schematic. It shows that in order to achieve the same goal, we each may need different resources, which is equity. One person may only need one step stool, another two-step stool, another three-step stools, all to reach the same objective. Again, with this little schematic, I like it because many times we confuse equality with equity. They're two different things. Although equality sounds great, equality means each individual or group of people is given the same resources or opportunities. And that sounds great, but equity recognizes that each person has different circumstances and allocates the exact resources and opportunities needed to reach an equal outcome. So in the schematic, you can see in the first one, we have it appears to be an apple tree, and we have equal ladders, equal height ladders on each side. But you can see one side, one individual is able to access the apples. The other, with an equal size ladder, still is not able to access the apples. Whereas in the other picture, you can see that when you supply the resources that are needed, both are able to access the apples. And I have just a quick video to share with you on what is equity. And we're going to see if we can work this out. Let's see. I think I'm going to have to stop sharing. Are you still there? Let's see. And Amanda, I think I'm having a little trouble. Let's see. You still there?
Yes, ma'am. We are still
Okay,
here.
here we go. Here we go.
Oh, got it. Awesome.
We hear a lot of people using the word equity, but what does it really mean? It's not quite the same as equality, which means everybody gets treated the same. Equity is about fairness. It means that everybody gets what they need based on their own situation, because we're not all the same. The difference between equality and equity is important. It's part of the reason the United States spends more on healthcare per person than any other advanced nation and has much poorer health. It's important to remember that a person's health depends on many factors, things like their environment, schools, and workplaces, to name a few. We call these social determinants of health, like clean drinking water for children and easy access to fresh food. We can follow the lead of communities like Columbia Gorge in Washington and Oregon, where businesses, doctors, and farmers tackled the local hunger problem with the Veggie RX voucher program. And the New Jersey Partnership for Healthy Kids is bringing down high rates of obesity in underserved communities. We should be inspired by these local efforts and remember that health equity is all about making things better for all of us. When everyone's healthy, everyone benefits.
Okay, so when everyone's healthy, everyone benefits. And let's see if I can get back to our PowerPoint. Does everyone see the PowerPoint? Not probably.
No, ma'am. We're not seeing it on our end.
Okay, well, I will get back here and then I will resume sharing. And do we see the PowerPoint now?
There it is. Yes.
Okay, great. Okay. So I hope that video helped to kind of explain the difference between equality and equity. So now why is health equity important to rural hospitals? And this is the core of these webinars, is to really address the importance of, which is because we know how extremely busy our rural hospitals and our critical access hospitals are in meeting the needs of the rural community. So health equity is vital for rural hospitals because it addresses the unique challenges and barriers that rural communities face in accessing healthcare, leading to better health outcomes for rural residents. And we know that improving healthcare outcomes for our rural residents is critical to really the survival of our rural communities and much of our economics here in Louisiana. So health equity addresses disproportionate health burdens. And we know that rural and underserved communities and critical access hospitals deal with patients that have chronic conditions, complex mental health issues, and deal with poverty. By prioritizing health equity, critical access hospitals and our rural hospitals can tailor interventions to address and specific health needs of the populations they serve, reducing health disparities and improving health in the population that is being served. So health equity increases access to essential services. Many of our rural hospitals are the only healthcare providers within the large geographic areas. Health equity efforts help to expand access through strategies like telemedicine, through community outreach, and transportation services, ensuring that distance or socioeconomic status does not prevent patients from getting necessary care. Health equity reduces emergency room dependency, which is critical. Our rural hospitals see patients who often delay care until they have severe symptoms, often due to barriers related to cost, transportation, or lack of insurance. Health equity initiatives, such as preventative care programs and partnerships with local organizations, can encourage earlier intervention and reduce costly ER visits and hospital readmissions. Improving health equity improves financial stability for our rural hospitals. By addressing social determinants of health, and we'll get more into the social determinants of health, our critical access hospitals and our rural hospitals can improve overall community health, which can lower uncompensated care costs associated with sustainable healthcare system by reducing the burden of high-cost emergency and inpatient care. Health equity builds community trust and engagement. Critical access hospitals and rural hospitals are often central to their communities. They are a part of their community. And a commitment to health equity strengthens this bond. When patients feel that their local hospital is committed to overcoming social and economic barriers to care, their trust and engagement tends to increase, encouraging individuals to seek care sooner and participate in preventative programs. And finally, health equity enhances workforce stability and cultural humility. Health equity initiatives often involve training staff on cultural humility. And I like to define cultural humility as having a humble and respectful attitude toward people of other cultures. We often use the term cultural competent, but the key there is that we never become competent in anyone else's culture. We're constantly learning. Cultural humility involves ongoing self-exploration combined with a willingness to learn from others. It helps us recognize our own cultural biases and realize that we can't know everything about a culture. We learn from our patients and their families, and we acknowledge their cultures and how these cultures affect health without making assumptions. Through these efforts, we can promote accessible, affordable, culturally proficient, and high-quality care, and that's our goal. And this enhances and creates a workplace environment that encourages and promotes and makes it easy to recruit healthcare providers to our rural hospitals. So, all of these terms that we talked about, social determinants of health, social drivers of health, health-related social needs. Well, you can really get confused within all the different terminology. And so what I'm going to try to do in this webinar is to help us differentiate between the different terms that are being used. And because each healthcare facility, each rural hospital within your community, within your team, you're going to have to come up with a definition that you want to use for health equity, and then the term that you'll want to use in terms of its social determinants of health, drivers of health, health-related social needs. So let's begin with social determinants of health. They are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, worship, and age. And these conditions include a wide set of forces and systems that shape daily life, such as economic policies and systems, development agendas, social norms, social policies, and political systems. And this comes from the CDC and World Health Organization. And then we have the social drivers of health, very similar to the social determinants of health, but they go a step further. Their goal, I'm not going to repeat the part in terms of the initial part because very similar to social determinants of health. But what they're saying in this definition is although sometimes called social determinants of health, social drivers of health emphasizes the active influence of social factors on health outcomes, suggesting that these factors can be changed or addressed, whereas some feel that social determinants of health imply that these factors are fixed and cannot be changed. So it's really a way of thinking. Social drivers of health said, hey, these are things that we can do something about, we plan to do something about so that we can improve health outcomes. Some feel that social determinants of health says that, hey, if I'm born in poverty, then I'm going to die in poverty because that's a determinant of my health. And people feel that that's not the way we want to present this. That no, these things do not determine your health, but they do impact your health, but they can be changed. Now, health-related social needs, and this comes from the Joint Commission. They're identified as the root causes of disparities in health outcomes. The Joint Commission uses the term health-related social needs to emphasize that these social needs are a primary cause of poor health outcomes. For individual patients, and this is a key for this, individual patients, when designing practical patient-centered care plans, as opposed to social determinants of health or social drivers of health, which they believe is better suited for describing populations. And again, this comes from the Joint Commission. So I look at the health-related social needs as when I was teaching nursing students, and we had to develop individualized care plans for the patients based on that patient's needs. So I see health-related social needs as more of a patient-centered focus, individual patient-centered focus terminology. All very similar. And then we have health disparities and health inequities and how they interrelate. And all of these things are really very closely related. Health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by people who are socially disadvantaged and are closely linked with economic, social, and environmental conditions. Well, health inequities are the systematic differences in the opportunities groups have to achieve optimal health, leading to unfair and avoidable differences in health outcomes, those health disparities. Health inequities are caused by the social conditions in which people are born, grow, live, and work and age. And again, we know those conditions are socioeconomic, based on ethnicity, race, gender, and so forth. So the goal here is just to show how all of these things are related. And what I did here, I just prepared a summary chart. We're not going to go over the summary chart, but it takes all of those terms and gives you just a very brief definition. The others were very much more detailed, and then how it relates to health equity. So when you have some time, I'm sure you'll have access to the PowerPoint, but it tends to kind of break it down in an easier way to really consume it, but it's really based on the previous definitions that we talked about. Now, I want to share just a model with you. Many of you, I'm sure you're familiar with the county health rankings, and which really show how the social determinants of health, the social drivers of health, impact health outcomes. You'll see the diagram that's to my left of Healthy People 2030 Social Determinants of Health. And again, it shows you how all of these elements play in the role that they play in terms of our health outcomes, healthcare access and quality, neighborhood and built environment, social and community context, economic stability, education access, and quality. And each of those things are broken down. And then you can see in the diagram to my left, which is really the county health rankings model that takes the social determinants. And what they've done, they've actually added a percentage as to how much each one of these contribute to the health outcomes within our state. And I think everyone is aware that based on the county health rankings, Louisiana rates 50th in terms of health outcomes for 2023. And I was at a health equity summit just this past 2 days at Pennington, and I think they said for the last 20 years or so, it's been pretty much a flat line. And so there's a goal now that we're going to move up to 40th. I think it's by 2030, I think is their aim, but I'm not exactly sure. But the goal is that we have to get away from 50. And we have to be strategic in doing that and developing a health equity culture, a health equity plan that is actually implemented, evaluated, and community involved is one important strategy to accomplish this. But you can see here that health behaviors such as tobacco use, diet, and exercise contribute approximately 30% to our health outcomes. Clinical care, having access to care, quality of care, which is essential, which is what our rural hospitals, our critical access hospitals provide for the people within the rural communities. And that contributes approximately 20% to our health outcomes. But we can see that approximately 50% of the health outcomes, social and economic factors, 40% contributes to our health outcomes, such as education, employment, income, family and social support, community safety, and then the physical environment, air and water quality, housing, and transit. And then you can see here that policies and programs. Policies are essential into changing conditions on a more systemic level. And so the policies have to be developed that go along with our health equity plan. And ultimately, the goal is to address these health social determinants of health and to improve health outcomes. So I just wanted to show just the schematic. So then I wanted to get into just a little bit, okay, how does this relate to Louisiana? You know, when we look at the social determinants or drivers of health, and we say income, employment, poverty, all of those things tend to drive healthcare outcomes in our state. Education attainment, race, ethnicity, sexual orientation, gender identity, health literacy, community infrastructure, environmental health, safe and healthy homes. Well, let's look at the inequities in our rural Louisiana. The poverty rate in rural Louisiana is 24% compared with 18.7% in urban areas of the state.
And that's you?
Hello?
Oh, did I?
18.8% of the rural population has not completed high school, while 12.9% of the urban population lacks a high school diploma. The unemployment rate in rural Louisiana is 4.1% compared to our urban areas of 3.6%. There are limited job opportunities available in our rural communities. People living in our rural Louisiana are less likely to have employer-provided health insurance coverage, and if they are poor, often are not covered by Medicaid. There are limited access to healthcare specialists and subspecialists. Over the last couple of years, I've had the opportunity to attend some of the Rural Health Association Well Ahead programs, webinars, and the idea that sometimes people will have to wait 6 months before seeing a specialist. We cannot say that that's fair or that's just. So those are things that we have to address. And I just added here, we've all seen on the news, Tulane researchers found exceptionally elevated rates of low birth weight and preterm birth, as much as triple the U.S. average in parts of Louisiana with the worst air pollution, including areas within Cancer Alley. So what I tried to show on this slide is that we see all the social determinants of health, and then where we see the inequities occurring, go back, that these social determinants of health you can see how they're amplified in terms of the inequities within our rural Louisiana, which means that we have to make a difference. And you know these. These are just a few, and the list is very short list. We can add to this list tremendously. But 11% of adults in rural Louisiana have heart disease, compared to 30% higher than the urban prevalence of 8%. 20% of adults in rural Louisiana have diabetes, 42% higher than the urban prevalence of 14%. 43% of adults in rural Louisiana are obese, 21% higher than the urban prevalence of 38%, and 39% of adults in rural Louisiana use tobacco, 12% higher than the urban prevalence, and the list goes on. I wanted to share with you, and I want to keep eye on my time, an example of where we want to go with discussions and our journey to developing health equity plan and policies. Here's an example. Roberta lives in a rural community and has taken to the rural hospital because she is experiencing shortness of breath and has high blood pressure. We're missing that high there. Her intake paperwork includes a screening assessment for health-related social needs, and that comes from Joint Commission terminology. It asks questions about her living situation, food security, transportation, utilities, safety, financial strain, employment, family and community support, and education. Remember that if we don't ask, we will not find out. And I know there's been many discussions within about health equity and developing health equity plan that, why should I ask something that I can't do anything about? But that's the goal. And I always say we can't address the whole elephant, but we can address a piece of the elephant at a time. So you can't expect, these things did not happen overnight. So rural hospitals can be expected to address all of these issues, but you can find those issues that impact your community, that are priority in your community, and then begin working with your community and community organizations to develop resources. Roberta's answers indicate that she will have difficulty paying for blood pressure medication and may have trouble getting to the clinic on her own for regular checkups. Well, what this does is sets Roberta up to, if I can't pay for my blood pressure medications and I can't get to my clinic appointments, then I'm going to end up in the ER very soon. After reviewing her health-related social needs assessment, a member of her care team meets with Roberta to better understand her needs, as well as to discuss the available resources in the community to address those needs. A care navigator at the health center finds that Roberta is eligible for a local nonprofit's financial help program, which could cover some medication costs. Okay. The navigator collects all the needed information from Roberta, her doctor, and her pharmacist to enroll her in the program. Additionally, the navigator arranges transportation between Roberta's home and the clinic with a local service for the aging. The navigator then follows up to make sure Roberta receives her medication and is able to follow her treatment plan. What I want you to see in this scenario is that health providers cannot do this on their own. There has to be a team working together, coordinating the patient's care, in order to address, to bring about better healthcare outcomes. And so finding those additional resources, finding human resources is going to be key. Community resources is going to be key in order to be successful. I also wanted to share with you that there are many, the CMS framework for health equity, they have set 5 priorities that they feel should be included within the goal of meeting a health equity plan, health equity goal, improving healthcare outcomes. And this is their framework for 2022 to 2032. Priority 1 is expanding the collection, reporting, and analysis of standardized data. Priority 2, assess causes of disparities within CMS programs and address inequities in policies and operations to close gaps. Priority 3, build capacity of healthcare organizations and the workforce to reduce health and healthcare disparities. 4, advanced language access, health literacy, and the provision of culturally tailored services. And 5, increase all forms of accessibility to healthcare services and coverage. What I want you to do is not to be overwhelmed by all of these frameworks because they are simply guides. The goal is that you begin this work. It's like one step at a time, but it's important that you make that step. And we believe that the first step is developing that health equity plan that will be up for continuous revision, that will be fluid, but developing that plan and developing policies to go along with that plan, and then implementing that plan. The American Hospital Association also has a framework, and they've identified societal factors that influence health. And it's really just restating, rephrasing what we've already been talking about: social determinants of health, social drivers of health, health-related social needs. But they look at the person in terms of who. When we're talking about systemic impact, anchor organizations such as hospitals and health systems, community leaders, legislators, and policymakers. These are the individuals, these are the people, these are organizations that can begin to address systemic causes of poor health outcomes. Settings, community, state, or national. And then we have examples: systemic race inequities such as racism, sexism, generational poverty, redlining by financial institutions, environmental injustice, educational systems. And then the goal is strategies. How do we strategize? How do we begin at the systemic level to address these issues? And then the community. Who? The community served by the hospital. And remember, we said the rural hospital is at the middle of the community, in the center of the community, where people live, learn, work, and play. And we have examples: food deserts, lack of affordable housing, those social drivers and of health. And then how do we address those? And then we talk about the person, individuals who present for healthcare services. And I equate this more with the health-related social needs, individuals, patient encounter at point of care, lack of stable housing, homelessness, limited access to healthy food, insufficient transportation. If we care for those patients and send them back in that same environment, we can expect to see them again. So the goal is, how do we strategize to meet the root causes of that, non-medical causes that are causing that person to return to our emergency rooms? Okay, I have another poll question. Have you read your healthcare facility's most recent community health needs assessment? Have you read your healthcare facility's most recent community health needs assessment? Okay, well, this is great. It looks like the vast majority of you have read your healthcare facility's community health needs assessment, and that is great. That is wonderful, because that is one of the beginning points for developing a health equity plan, because you have extremely valuable information in those community health needs assessments. So that's great. Okay. So now we're going to talk about leadership, and I'm watching my time. We're going to talk a little bit about leadership, because leadership is key when we're talking about creating a culture of health equity and creating a health equity plan that's going to be held accountable, and that's going to be implemented and evaluated. So a strong commitment from the C-suite is crucial for advancing health equity in healthcare, because it signifies a top-down organizational priority. It becomes a priority, allowing for the allocation of necessary resources, strategic planning to address disparities, and a culture shift that integrates equity into all aspects of operations, ultimately ensuring that everyone has equal access to quality health care, regardless of social determinants or social drivers of health, like race, ethnicity, or socioeconomic status. So we're looking at leadership and vision. We're looking at resource allocation. We're looking at policy and procedure implementation. We're looking at culture change, stakeholder engagement, accountability, and measurement. And we know that unless we have a strong commitment from the C-suite, that this will not be successful. Okay. Next, we have the health equity officer or leader. Identifying an individual to lead the organization's activities to reduce healthcare disparities establishes clear lines of accountability and ensures that staff have the support necessary to implement successful initiatives. Multiple organizations and individual experts recommend having a designated leader for health equity efforts. And this comes from the Joint Commission. And the key here is that identifying a person that can influence with has influence with frontline staff, physicians, and other key personnel. And it doesn't have to be a physician. In many organizations it is, but it doesn't. But it has to be a champion, instrumental in garnering provider buy-in and practice change. However, depending on the project, it can be any key personnel with authority and skills to influence change, led by example, and assist in essential messaging of the goals and vision for a project. So that the leader is extremely important. And I have another video. And so I'm going to see if I can stop sharing and then PowerPoint.
The role of a health equity officer, someone who is responsible for system-wide leadership, is important because of the responsibility that it has to provide not just service to the community, but impact and results. To move the needle in equity really means that you have to do concrete and tangible actions, but they have to be the right actions. And especially now, we've seen with the multiple pandemics, with the social unrest, the overt racism, we've seen with COVID, all of the manifestations of what happens when you don't do something. So we can't continue to do that, nothing. So doing something means not just doing anything, but doing the right things and doing the right things well. So it's important, especially now, that we get it right, that we get into action. We stop the pontificating around what we should be doing and we actually do it, but we do the right things with the right timing. And it also helps to hold organizations accountable. You know, we say that we're about equity. We think it's a priority. Many organizations have it in their mission statement. And so, okay, saying it and doing it are not necessarily synonymous. And so it's really important for organizations to live their mission of equity, and chief health equity officers help them do that. And then when you assign somebody as part of their responsibility, that really grounds it in action as well. It's not just a nice thing to do. It's something that's part of the organization. It's built into the organization, and it's actually built into the leadership of the organization. So clearly the buy-in's there.
Okay. Okay. Did everyone see the video?
So we can't see it, but we can hear it.
Okay, I'm sorry.
That's okay.
Well,
I didn't want to interrupt, but we'll get that figured out.
Okay, all righty. Well, so I hope that in listening to at least listening to the video, that you heard the importance of having of that health equity leader, that health equity officer. It's essential to carrying out the work of and the accountability associated with the health equity plan. So the health equity team, a leader can do nothing by him or herself. You must have a team. And the team should consist of representatives from key areas throughout your facility with the skills and the knowledge and the experience in their fields of expertise. A team member should possess strong communication skills, have a collaborative mindset, and show a commitment to change. It is vital to have representation from frontline staff, because they're going to be very important in really carrying out this health equity plan. It is also important to keep the size of the team manageable. Remember, a team can have ad hoc members whose role is to provide expertise in a specific area for a short period of time. So the leader and the team are essential in caring, and they're essential in also making the whole facility, all the staff within the facility feel a part of this health equity initiative. So, advancing health equity is as much about changing perceptions and mindsets as it is about education, data, structure, and metrics. So it's not only we can have the data, we can do the seminars and the webinars and the training, we can establish a structure, but we have to have the mindset and the passion to really believe that this is going to improve healthcare and healthcare outcomes within our community. And this is going to impact how we practice and how we structure the care that's given to those in our community. So now we're moving next, our webinar number 2, which will take place on December 12th, and I hope to see all of you back and even more. It's going to be looking at the health equity journey in rural communities. Where do we begin? And I have an assignment, and it's a very brief assignment, easy assignment. The fact that the vast majority of you have read your community health needs assessment, I'd like for our next webinar, we want to hear more from you and share more with you, to please review your healthcare facility's most recent community health needs assessment and identify the top 3 health needs of the community and bring that back with you for our next session. I've included some of the resources. Some of these will be ongoing, but I want to make sure that you have access to any resources that I've used during these presentations. So now I'm opening it up for questions. Do we have any questions in the Q&A, Amanda? Or any comments that anyone would like to share?
I don't see any questions in the chat.
Okay. All righty. So I really want to thank you for your time again. I look forward to working with you in the future. Here's my email address. That's probably the best way to get in contact with me. Anything that we talk about on these webinars, I'm happy to meet with you, to talk with you about how we can assist you through Well Ahead in implementing or creating your health equity plan. You're going to see that as we move forward, we're going to even get into how we can even fund some of the initiatives and once we develop our health equity plan. So I really, really want to thank you for your time with us here on today. You're going to be receiving just a brief evaluation because we want to make sure that with each webinar, we're meeting your needs, that we're meeting the objectives that we've set forth. So if you would just take time again out of your busy schedules and should take maybe 2 or 3 minutes to complete that evaluation once you receive it and send it back in, we would really appreciate it. And if there are no questions or no comments, I want to give you back, it looks like I'll be able to give you back 4 minutes of your time. And so again, we want to thank you. Well Ahead, I want to be sure and thank you. And please encourage others to participate in these webinars. We're looking forward to working with you. Thank you, and you have a great day.
Thank you so much, Dr. Bienaimé. We appreciate you.
Thank you.